Hey guys, welcome back. I'm Carly again, one of the infectious diseases fellows here in Bethesda. We're going to be moving into some gram-negative organisms now and framing the first part of our talk as Pseudomonas. So Pseudomonas is also kind of a commonly implicated bug in hospital-acquired infections, as well as patients that have underlying risk factors for more multi-drug resistant pathogens. So we still have our risk factors here in purple when we talked about MRSA, so recent antibiotic use, recent hospitalization, long-term care residence, history of previous culture isolation. For Pseudomonas, we're going to add a couple more. So patients that have poorly controlled diabetes are at higher risk of pseudomonal infections. Same with patients with cystic fibrosis, underlying bronchiectasis, and then notably Pseudomonas likes to hang out in water sources. So patients that have a significant water exposure can also be exposed to this bug a little bit more. So jumping right in, like Pseudomonas is kind of commonly implicated. We always want to worry about Pseudomonas in hospital-acquired pneumonia, ventilator-associated pneumonia. It can also be implicated in wound infections, UTIs, bloodstream infections. So we'll get right into talking about drugs that provide good coverage for Pseudomonas. So we're talking about empiric options, and then we'll go into a little bit more sort of specific situations. But when you're looking at sort of empirically covering Pseudomonas, if you're concerned about any of these overlying risk factors, or even if your patient is just really sick and you don't know what's going on just yet, we have sort of three main groups that are our workhorses for empiric Pseudomonal coverage. So our first group is our Cephalosporins. And within that group, we have two drugs that are in this class that have good Pseudomonas coverage. So the first one is Cefoxitin, which is actually a third-generation cephalosporin. And really more commonly used is a fourth-generation cephalosporin called Cefoxitin. These are both pretty well tolerated. They have the same sort of beta-lactam type side effects that we talked about in the previous lecture. Cefoxitin specifically has been linked to having some neurotoxicity in patients that have maybe underlying are higher at predisposition for like seizures or altered mental status. So just be aware of that. The second class we're going to talk about in terms of good empiric Pseudomonas coverage is your Carbapenems. And specifically, we have three major Carbapenems that we use sort of in general in hospital medicine. We have Meropenem, Imipenem, and Ertapenem. When we're looking at Pseudomonas specifically, we want to sort of cross Ertapenem off that list because it doesn't have good Pseudomonal coverage. So really when we're trying to cover this bug, our main workhorse is going to be Meropenem. And then Imipenem can also cover Pseudomonas. We classically, at least here in our institution, don't use Imipenem nearly as much because this can lower your seizure threshold and also predispose patients to having seizures. So really Meropenem is what we usually go with in terms of this class. And then our next class of drugs that are good sort of empiric first-line coverage for Pseudomonas are our beta-lactam, beta-lactamase inhibitors. So in the previous talk, we talked about Amoxiclav and Amsulbactam. When we're looking at Pseudomonas specifically, we're looking at Piptazo, which is Piperacillin tazobactam. More colloquially known as Zosyn, but we're going to call it Piptazo for the rest of the talk. So this is sort of our common workhorse when we look at empirically covering Pseudomonas. Like I previously said in the last lecture, when you combine Piptazo with vancomycin for empiric sepsis coverage, or even HAP coverage, VAP coverage, you want to worry about nephrotoxicity because it compounds the effect. So patients that have underlying renal dysfunction, you may not want to pick that combination. We have a couple other beta-lactam, beta-lactamase inhibitor combinations that do cover Pseudomonas, like ceftaz-avibactam, ceftolozane tazobactam, but those are usually involved with ID subspecialty consult, so they're really not sort of our empiric first-line choices, so we're not going to really go into them here. So these are really our common first-line choices for empirically covering Pseudomonas. Obviously, your choices can be guided by your culture and sensitivity reports, and if you end up not isolating Pseudomonas, you can always de-escalate to a less broad agent. Another class of antibiotics that does cover Pseudomonas, though, are fluoroquinolones. And specifically, when we say fluoroquinolones, we say ciprofloxacin and levofloxacin. However, the increasing rates of Pseudomonas resistance to these drugs really preclude them from being good empiric choices. So really, we only use these drugs, sort of oral step-down therapy, or after you culture Pseudomonas and you find that it's sensitive to those bugs, but these are really not great first-line choices for empirically covering Pseudomonas. Some important things to note about fluoroquinolones is that they have so many side effects that you need to be aware of in hospitalized patients that are at increased risk for complications. So the one that's classically on board exams that we always see is tendinopathy. So, which is really a lot more common in your elderly patients that are already frail and sort of have aging ligaments and bones. Along the same lines as tendinopathy, the proposed mechanism is that it sort of can interfere with type 1 collagen. So the newest black box warning for fluoroquinolones involves sort of pretty significant vascular side effects. So you can see aortic dissection or aortic aneurysm. And these are really going to be in patients that maybe have predisposed risk factors for these underlying things. It's just an important side effect to be aware of. So if a patient already has underlying vasculopathy like this, you maybe not want to choose this. So fluoroquinolones also classically can prolong your QT interval. So typically I like to at least look at a baseline EKG prior to starting these drugs on anybody. So that's also something important to be aware of. In your elderly patients, this can also be a deliriogenic medication, so it can increase delirium. And then it can also cause sort of fluctuations in your glycemic control, so it can cause episodes of hypo or hyperglycemia in at-risk patients. So these are all just things to be aware of when you are starting the medication. So other drugs that can cover Pseudomonas that really we're just going to lightly touch on because usually ID is probably on board at this time already. But as Trianam is a good option for patients that have severe reactions to penicillins or beta-lactam. So this is what we usually go to if there's pretty significant documented plausible allergy. Aminoglycosides are less frequently used nowadays, just especially in empiric coverage because they have so many side effects. Not only are they nephrotoxic, but they're also ototoxic and can cause hearing loss. So if you are going to go for an aminoglycoside, make sure you at least get a baseline understanding of a patient's hearing before you do that. And then really colistin is sort of a last-ditch antibiotic that really wouldn't be used unless ID is on board, but just something to be aware of that it's out there, but we're not going to really touch on that today. So really the most important column in this section is this left-hand side here. These are going to be your empiric choices to cover Pseudomonas. So I'm just going to take a quick break and erase the board, and then we're going to move on from Pseudomonas and talk about some other sort of commonly seen infections in the hospital that are implicated by gram-negative organisms. So if we start by sort of looking at, let's say, a UTI, patients that have UTIs, it's a very common infection that we see and treat in the hospital. So I'm going to erase these risk factors too for Pseudomonas here. But these ones are going to stay because we're going to talk about some other resistant bugs in a little bit. But if we look at UTIs, it's a very common complaint that people come to the hospital with. And really, in your patients that don't really have any of these underlying risk factors and haven't cultured anything in the past or have any structural urologic abnormalities, for really mild, uncomplicated cystitis in patients, we have 3 good first-line drugs. And the reason why these are first-line is that most of the time in uncomplicated cases, E. coli is our #1 culprit. So for mild infections, we have 3 sort of first-line agents that we use. So one, we're going back to trimsulfa. And we already sort of discussed side effects of this drug. The next one we're going to go is a drug called nitrofurantoin. This is also known as macrobid. This is a really good first-line option for mild cystitis. And then the third is a drug called fosfomycin. I think I'm going to need to change marker colors. So these are good first-line options. According to Idsa Guidelines, these are our first-line choices for mild uncomplicated cystitis in patients presenting with UTI symptoms. Notably, nitrofurantoin is contraindicated in a GFR less than 30, so we don't want to use that for patients that have underlying bad CKD. In patients that have underlying sort of interstitial restrictive pulmonary processes, this can also cause pulmonary fibrosis, so that's just another important side effect to be aware of. And then fosfomycin is pretty well tolerated in mild cystitis. This drug, it's just a one-time dose usually, so it is pretty well tolerated, but also not really indicated in patients with chronic kidney disease. Notably, nitrofurantoin and fosfomycin don't penetrate the kidney, so these drugs are not used in pyelonephritis. Some second-line options, so if for some reason these first-line options aren't working, so for your mild cystitis, we also have beta-lactam, so you can use amoxicillin, ampicillin, if you need IV coverage. You can also use ceftriaxone, which is a good option. Has pretty good gram-negative coverage, just not with multi-drug resistant organisms. And then also sort of second line for mild cystitis, depending on why you would choose it, would be a fluoroquinolone as well. So same drugs that we talked about before, Cipro and Levaquin. So these are second line options for sort of just general UTIs without any risk factors for underlying resistant disease. But notably, if you have a patient that has more systemic symptoms or has pyelonephritis, which is an upper urinary tract infection, you're going to want to reach for ceftriaxone or fluoroquinolone. I classically go with ceftriaxone first just because it's better tolerated. And so we already sort of went over main side effects of these fluoroquinolones as well. So these medications that we just talked about are good first-line options for patients that are just coming in without many risk factors, but for urinary tract infections. So our cystitis up here, and then some of our first choices for pyelonephritis here. Now let's say your patient does have risk factors for underlying resistance, so they recently had antibiotics, hospitalized, we kind of already went through this list, or if they've had a previous culture isolation that's a gram-negative pathogen like E. coli or Klebsiella, something that's resistant to our typical antibiotics. Some of these drugs are called Esbl organisms, which mean they produce a beta-lactamase that inactivates beta-lactam antibiotics. We also have some Anaerobic Bacteria that are resistant inherently to Carbapenems, but those are pretty, more advanced, usually involving an ID consult. But Esbl is a common type of bacteria that we do see in the hospital. And this basically just stands for extended spectrum beta-lactamase. And this can be seen with a lot of different Anaerobacteriaceae. And really the main thing you guys need to know for Esbl empiric coverage is really just, it's not a really long list. So we look at Esbl, if your patient has a history of growing an Esbl in the past, or if you are pretty high suspicion, if they're sort of failing empiric therapy and you're waiting on your cultures, it's reasonable to cover for Esbl. And the #1 drugs of choice that we use to cover Esbl in the hospital empirically before we have our culture data back are Carbapenems. And specifically, here's where ertapenem comes into play. Because ertapenem, like we already talked about, doesn't have Pseudomonas coverage, but it is really good for other gram-negative bacteria in the setting of beta-lactamase production. So ertapenem is going to be sort of first line if you're looking to cover Esbl infections and you don't have that extra Pseudomonas risk factor. But if you are also worried about covering for Esbl and Pseudomonas together, then you can certainly go a little bit broader with Meropenem. And like we said before, imipenem, not at least frequently used in our institution because of its risk of increasing the seizure threshold, or sorry, lowering the seizure threshold, increasing the risk of seizures. So these are the two that we usually use to cover ESBLs. So just a quick note on that, it's good for empiric coverage. The last class of bacteria that I want to cover sort of in the hospital are going to be our anaerobic bacteria. We haven't really talked about anaerobic bacteria yet, and anaerobes can commonly be implicated in not only sort of upper infections like dental abscesses, brain abscesses, lung abscesses. Kind of a common thing is that they're involved in abscess formation, but they can also be involved in lower infections too, so like abdominopelvic infections. So it's important to know what drugs have good anaerobic coverage. So sort of main classes to cover, we also have gram-positive anaerobes and gram-negative anaerobes. So I'm not going to sort of separate them because a lot of them have sort of mixing sort of a spectrum of coverage, but a lot of anaerobes are susceptible to clindamycin, which we already talked about. Clindamycin we use a lot for sort of upper anaerobic infections like dental abscesses. It's really great for. So that's just something to be aware of as well if you're concerned if patients coming in with like an odontogenic infection. Another good anaerobic drug is metronidazole. This is also called Flagyl. So metronidazole we use a lot for sort of GI infections. It's got pretty good anaerobic coverage. It covers a lot of different sort of gut anaerobes, so we use this a lot in intra-abdominal infections. A couple side effects of metronidazole. One, it can cause sort of a metallic taste, and that tends to be something that patients tend to complain about a little bit more. And then I'm sure you've all heard also of a disulfiram type reaction. So this medication is not to be combined with alcohol. Patients can feel really poorly on it, which is really not, hopefully, a big deal in inpatient medicine. So that is a good drug for sort of your abdominopelvic infections where you're looking for anaerobic coverage. We also have a couple of our previously mentioned beta-lactam, beta-lactamase inhibitors. And so we've already talked about amoxiclav, which is Augmentin, amsulbactam, which is the IV formulation, it's called Unison, and then piptazo, which has a little bit broader coverage, but also good anaerobic coverage, so a good option for broad coverage if your patient is a little bit sick or septic. Along those lines too, so these are good drugs that cover anaerobes. Our carbapenems also cover anaerobes. So when you're sort of looking to cover broadly in a patient coming in that's really sick, this would be a good option too. So we kind of already went over all the carbapenems, but just know that the carbapenems have good anaerobic coverage. And then last, we also have a fluoroquinolone that we haven't talked about yet called Moxifloxacin. Moxifloxacin is a good sort of second line choice in some pneumonias. It has good gram-positive coverage. It's known as a respiratory fluoroquinolone. But another sort of attribute of moxifloxacin is that it has good anaerobic coverage, whereas ciprofloxacin and levofloxacin do not. So this is good for anaerobic. Unlike the other two, it doesn't have Pseudomonas coverage. So it's not something that we really like to use when we're concerned about that. It also doesn't penetrate the urinary tract very well, so not great in urinary tract infections, but we do kind of put it up here with our anaerobic infections because it does have good coverage. And moxifloxacin has pretty much all the same side effects as the fluoroquinolones that we already went over. And then we have a couple other sort of more niche antibiotics that cover anaerobic infections that I don't really use in my practice, but they are still out there. So just to be aware of, we have 2 second-generation cephalosporins. So Cefoxitin and Cefotetan. These 2 drugs have increasing resistance to B. fragilis, which is a common anaerobe that's found in the gut, so really not used as much anymore. And these I still see sometimes in like pelvic infections where there's less sort of B. frag in the pelvis than there is in the gut. So you can just be aware of these. I don't commonly use them in empiric anaerobic coverage, but they do exist and they're second generation. So we've also went through drugs representing each class of the generations of cephalosporins too, which is helpful. So these are my main drugs that cover anaerobic infections. It's certainly not an all-inclusive list, but these are the ones that we reach for sort of first line when we're looking at different types of infections. So this is it basically. We're gonna wrap up now.